going to review what the inheritance of FSH is. So genetic traits, genetic disorders can be inherited in different ways. So we have 2 copies of every chromosome, and we get 1 copy of each chromosome from each of our parents. And it's completely random whether you get this copy or that copy. It's like a flip of the coin. And the 3 main ways things can be inherited are dominant, recessive, or X-linked. And FSH is a dominant disorder. So what this means is that if 1 copy of your chromosome 4 has the deletion, that would be enough to cause FSH. And so in each pregnancy, a person with FSH conceives, there's a 50% chance they pass on the copy of chromosome 4 with a deletion, and a 50% chance of passing on the normal chromosome copy. And it's totally random, it's independent in each pregnancy. So statistically, if you had 4 children, you'd think that 2 of them would be affected and 2 of them wouldn't, but that's not always the case. It could be all 4 affected, none affected, some combination there, because it's independent in each pregnancy. So that's pretty straightforward, but there are some complicating factors with FSH. So one of those is that some patients, about a third of patients with FSH, they have a de novo deletion, meaning that neither of their parents has the deletion and neither of their parents has FSH, and the deletion just happened totally new and randomly in them. And so if you were to test their parents in their blood, it would be negative. They would not have the deletion on either copy of the chromosome. And there's nothing that causes this to happen. So a question I get a lot is, well, what did I do to cause this, or what did my parents do, or was it something I ate or drank or somebody's environment? It's just totally random. If you think about it, when we go to make our eggs and our sperm, we have to copy 3 billion DNA letters. And if someone said to you, can you please copy 3 billion letters and not make a single mistake? Of course you're going to make a mistake. And this region is highly repetitive. So if you have to copy something exactly 100 times, you might lose your spot and put in too few repeats, right? So that's how I think of it in my head, that when these deletions happen for the first time, it's completely random. But once it happens and a person has the deletion, then they can pass it on to subsequent generations. We also know that there can be something called mosaicism, which means that the deletion is present only in a subset of cells or tissues in your body. It could be germline mosaicism, meaning that it's only in your eggs or your sperm, and so nowhere else in your body do you have the deletion, so you would have no symptoms of FSH, but you could have 1 or more children with FSH. Or sometimes it could be somatic mosaicism, meaning it's throughout the body, but not in every cell in the body. So that could be one reason why a person might be more mildly affected, is if they only have the deletion in some of their cells or tissues, then maybe they wouldn't show the full disease. So it's something we think about, if I'm counseling a family who they have a child with FSH and their blood testing is negative themselves, both parents, there's still a small chance of having a second affected child, because it could be some mosaic, either somatically or in germline mosaicism. So other kind of complicating factors are what Dr. Leung has already talked to us a lot about, this reduced penetrance and this variable expressivity. So reduced penetrance means not all people with a deletion will have FSH. And there must be other factors, other genetic and maybe non-genetic factors affecting that. And we've started to unravel some of those other factors, but there's still some that we don't have figured out yet. And then variable expressivity, which refers to different levels of severity and age of onset even within a family. So you might have a child who presents very early on and their parent is only very mildly affected or didn't show symptoms until later in life. Again, there must be lots of other factors that are playing a role in this pathway of DUX score being expressed that affects how it shows up in a person. So that can make things complicated when counseling families, especially because we can't tell all of this just from a genetic test. So what I can tell you from a genetic test is, do you have a deletion or not? Or do you have the A haplotype or not? And if I'm looking at a genetic test result, I can't predict what is the severity going to be, when is it going to show up, will it ever show up? So that can be hard, especially when thinking about reproductive decisions, because there's no way to know or tell. It's unpredictable at this point. So that's with type 1 FSH. So type 2 FSH is inherited differently. So rather than just being a dominant pattern, it's called digenetic inheritance. So the genetic changes that are needed to cause the disease, the A haplotype and the SMC gene mutation, they're located on different chromosomes, which means they're inherited independently from one another. And a child has to inherit both the A haplotype and the SMC gene mutation in order to have the disease. So it's not going to be a 50-50 chance. It'll be less than 50%, but it depends on the genetic status of the parents. So just to show you how complicated it is, this is a pedigree from the paper that reported these families with SMC gene mutations. And what this is showing you, so up here, this square, so in a pedigree, in a family tree, squares are males and circles are females. So this is showing the grandfather up here who has the SMC-HD1 mutation, but he only has the E haplotype. So he's unaffected, does not have FSH. Because the SMC gene mutation by itself doesn't cause any problems that we know of.
But he can pass it, correct?
Exactly, he could pass it, yeah. And the grandmother over here does not have an SMC gene mutation, but she has the A haplotype. But again, the A haplotype by itself doesn't cause any problems, it's fine. So one of their children, this person here, inherited the SMC gene mutation from his father and inherited an A haplotype from his mother, so he has FSH, whereas his siblings, they all inherited the normal SMC gene from the mother, and it doesn't really matter whether they have A or B haplotype. And then this person's children, he happened to pass on the normal gene copy to both of his children. So, and it can look a whole bunch of different variety of ways depending on the combination of parents. That's what it can get complicated. But for the most part, with FSH, we're dealing with dominant inheritance, 50-50 chance of passing it on.